I'm Cliff Fullerton. I'm the Chief Medical Officer for Baylor Quality Alliance and also the Vice President for Chronic Disease and Care Redesign for Baylor Health Care System. Well, it's interesting. Most people think equitable health care means delivering the exact same care to everybody, but really it's creating the exact same outcomes for everybody. Sometimes actually the part of the problem with not achieving the same outcomes is that you are treating people exactly the same, and culturally they need to be treated differently. Sure, Baylor over the years has had many initiatives to try and improve health outcomes for racially diverse populations. Several years ago, we started the Office of Healthcare Equity and assigned a Chief Equity Officer. Creating this office and the leadership related to that allow senior leadership to focus on disparities of care and come up with plans for trying to improve care. One of the outcomes of that was a project called Project Access, which was an effort to try and pull in volunteer resources from the healthcare community, from primary care to specialty care to hospitals to pharmacies to imaging centers, and get them to agree to provide some level of care that they were willing to do, and then coordinate that care between those different providers. In doing that, we were able to reach a lot of patients who did not have access to care and provide them with high quality health care in the settings that those providers were used to dealing with. That project got moved to the Dallas County Medical Society and has been impactful for a lot of patients in the Dallas County. Another project was the Diabetes Equity Project that came out of this same office. In that project, we attempted to deal with culturally diverse issues by using community health workers, people that were educated from the community of patients that could then help translate the care that was trying to be delivered from the providers to the patient's own culture and their language and their understanding. This project significantly improved diabetes in a cohort of patients that were of Hispanic origin. The other structural tools that we've been able to use are the Baylor Community Care Clinics. These clinics sit with our employed physician group and are as an effort to provide access to care for people that traditionally have poor access and in neighborhoods that traditionally have poor access. These physicians and the teams that are around them are develop the same resources and skills that are in our traditional practices in suburban settings where resources are more accessible. These practices have achieved level 3 patient-centered medical home recognition from NCQA. They have electronic health records. They have achieved excellence in diabetes care and have provided improved preventive services and access to 24/7 coverage for patients who traditionally don't get that. One of the lessons that we learned is that healthcare providers tend to come into a discussion about disparity thinking that disparity is caused by not providing the same care. And so they remember that they always provide the same care. They never withhold care from anyone. And so they feel like that when you bring data to them that shows disparities of outcomes, that it's maybe pointing a finger at them. And they may become defensive about that. Helping them to understand that actually many times the problem is that they are provided exactly the same care and that the care needs to be culturally different. That takes away some of the blame because many of our staff have not been educated on recognizing those differences or having resources or tools to actually address those issues. So one of the lessons that we've learned is that we need to provide that and help educate our staff on many of the reasons that we see disparities that are related to race or ethnicity. An additional challenge, or with this lesson that we've learned, is that collecting data is not always simple. To collect the demographic data and identify patients' race and ethnicity was more challenging than we thought. Educating our access staff, the people who are checking patients into a practice, on the differences in racial and ethnic differences, and then getting them to actually stop and collect that data was challenging. Many times the staff wanted to look at the patient and say, this is what their race is, rather than allowing the patient to take the time to say, this is what race I am. And that time that it takes to do that, and then the remembering to document that, was a challenge, and took us quite a while to educate our practices to collect that data so that we can then begin to identify the disparities in outcomes. Probably the most rewarding thing was to have the time to sit back and take an inventory of what Baylor's done over the last many years of trying to address these cultural disparities. By doing that, it reminded me of the tools that we have in place, the foundation that we have in place, that will allow us to continue to close the gaps in outcomes that we do see in our healthcare system and in this community. Additionally, it was nice to have the opportunity to recognize the work of many people who did great jobs in trying to help us understand these disparities and begin to close those gaps.